Thank you for coming to our last edition of the Lunchtime Faculty Research Presentation Series. I'm Jeff Herrick, the Executive Dean of the Research Center. And we are grateful for all our presenters and all our attendees as we build these talks. Please look in your email next week or so. We do have a full schedule in the spring semester as well. And an open call as always. If you'd like to present, just email us or me, and we'll gladly get you on the calendar. But enough logistics, let's talk about our presenter today. Professor Amanda Pribble is an assistant professor of nursing in the School of Medicine and Health Sciences. She is a 2005 alumni from the University of Lynchburg and has worked as a registered nurse in the open heart surgery intensive care unit at Centra Health. While working as a registered nurse, she completed her master's degree in nursing and family nurse practitioner degrees at the University of Virginia. Professor Pribble has extensive experience as a nurse practitioner in long-term and skilled nursing facilities. Professor Pribble's experiences as an RN and NP, as well as personal experience with death, have led to her interest and passion for end-of-life care. While working as a nurse practitioner, she was selected to attend an intensive and immersive 5-day advanced palliative care nursing externship at Virginia Commonwealth University, where she furthered her passion for palliative and end-of-life care. Professor Pribble began working at the University of Lynchburg in 2014 and began as a simulation educator around 2017, where she became a certified healthcare simulation educator in 2020. Her research interests are in simulation, end-of-life care, and test anxiety, and her aim for the presentation is to expand our understanding of simulation in healthcare education and how a simulation with an interdisciplinary team was implemented, and to gain an understanding and appreciation for end-of-life care. Please welcome me and Professor Amanda Pribble.
Hi everyone, I'm glad to be here today. Thank you all for coming, and I hope, as Dr. Herrick said, that we can have further discussion and learn more about simulation and end-of-life care. Just a little bit about expanding on what he said about my end-of-life care experience. In the ICU, I know a lot of you are in healthcare in this room. I faced a lot of situations that caused me a lot of moral and ethical distress. And so when I became a nurse practitioner, I kind of went to the other end of the spectrum with long-term care and skilled care. And during that time, I really had a lot of wonderful mentors, people that worked with me in hospice care, social workers who influenced kind of having to have those conversations with patients and their families. I was kind of forced into that and then developed a love for it. Personally, I lost a grandparent when I was 9 years old. That's kind of why I became a nurse. And so that has impacted kind of my whole life. I've had a lot of death in my life, I feel like. My dad died when I was 13. My grandparents have subsequently died, and I've been fortunate to be involved in their end of life and in my husband's family's end of life processes. I consider it a gift to be with someone when they die, and I hope I can impart some of that to you as well today. Nursing students are very anxious about this simulation oftentimes. It also doesn't help that this is like their first simulation of their junior year. We place it there because it's a less technical simulation and more of a communication simulation, and that's what I'll highlight some of today as well. One of the things a key takeaway that I tell the students, end of life care, if you can be nothing else but empathetic and a listening ear to those families, that's really important. And then I try to normalize the discomfort for them, and we'll talk about how I try to overcome some barriers with end-of-life care thoughts and things that we have from a society that we believe about end-of-life care and or experiences right ourselves. So we talk about that, and again, I just want to acknowledge that this might not be a comfortable topic for you today, and hopefully I can make it feel a little more comfortable. The other thing that I want to do is really take an opportunity to talk about simulation. I love simulation. It's my favorite way to teach. And so The first part of this is mostly going to be focused on how we use simulation in nursing. Maybe it'll spark some interest in you and how you could use simulation. And so I bet you thought when you came to an end-of-life simulation that I would not be opening with a Monsters, Inc. snippet. However, here we are. So we're going to watch this, and I want you to think about how this might apply to simulation in nursing. Hopefully we have sound. I don't think the sound is working. Anybody know how to get the sound to work on this?
Try that one right there.
This one?
Yeah.
Now I'm gonna blare us all out of here. Let me. Nope. I still don't think it's working. Let me fast switch over to. Oh, there it goes.
Simulation terminated. Simulation terminated. Simulation terminated. Simulation terminated. Simulation terminated.
All right, Mr. Vile, is it?
My friends call me Phlegm.
Uh-huh. Mr. Vile, can you tell me what you did wrong?
I fell down.
No, before that. Can anyone tell me Mr. Vile's big mistake? Anyone? Let's take a look at the tape. Here we go. Right. There. See? The door. You left it wide open. And leaving the door open is the worst mistake any employee can make because...
It could let in a draft.
It could let in a child.
Oh, Mr. Waternews.
There's nothing more toxic or deadly than a human child. A single touch could kill you. Leave a door open, and a child could walk right into this factory, right into the monster world.
I won't go in the kid's room! You can't make me!
You're going in there because we need this. Our city is counting on you to collect those children's screams. Without scream, we have no power. Yes, it's dangerous work, and that's why I need you to be at your best. I need scarers who are confident, tenacious, tough, intimidating. I need scarers like James P. Sullivan.
All right. So, I hope my students would say that I do not have anything in common with Mr. Waternews, but we would have to ask them for sure. Let me go back, sorry. Oh, we can leave that there for now. So, just like in the simulation world for monsters, right, we send our students into a simulated training area, right? They're training to scare children. Hopefully we're training our students to be kind and competent nurses in the world. We love simulation, just like here where he's practicing gathering his scares, right? And we see that he falls down on the jacks and makes a huge mistake, right? There's no child to be let in the door, right? So all of those mistakes can happen in a safe learning environment, which again is what we strive for in simulation with our students. After simulation, like Mr. Waternews came in and she was pointing out like what went wrong here, right? We would call that debriefing, okay? We usually don't like terrify, like the monsters were terrified and like hopping on each other. We try not to do that to the students, right? We want it to be more meaningful to them and more of a learning experience. And so again, we use it for how to improve, right? They're trying to improve his scare tactics, and ultimately, right, that's what we're trying to do with our simulations in nursing. So I hope that at least lightened the mood a little bit in a difficult topic that we're talking about. Now I would ask if you have a device. This is a Slido. Has anyone ever used Slido? And it's an add-on in Google Slides. I'll be using it throughout the presentation. You can open it in a tab and just kind of leave it lingering there, and then we'll come back to it periodically. So the QR code won't read. If you go to slido.com and just enter the numbers, it should pop up. Okay, so just to see kind of where we are, if you can just use 1 to 2 words, as the students have figured out, you can also use emojis to define simulation, just what simulation means to you. Good. So we have safe to make mistakes, which is really important. And experiential learning, which is wonderful. We can practice in a safe. Safe is becoming large, so a lot of people have said safe, which is really important. Obviously, we want it to be a learning environment for the students. We do want it to be fun. Some of my students argue that some are more fun than others, right? Engaging. Real world-ish, I like the ish, right? We do a lot to try to simulate fidelity in our simulations and realism in our simulations. Good, interactive. You guys have a great understanding of what it is. Innovative teaching, good. So just to kind of sum up what we've said, simulation, nurturing education, and many of you I know are in healthcare too. There are many modalities. Kind of newer on the scene is VR, and a lot of computer-based simulations really took off with COVID. So the modality that I'm talking about today is using a high fidelity simulator. So a high fidelity simulator has breath sounds, has chest rise and fall, has heart sounds, usually bowel sounds, usually all pulses in the body as well. There are different models that have different things. Some of them have pupils that react, some of them can bleed and sweat and simulated cry. So in the model that we're talking about, that I'm talking about today, that I did this research with, was a high fidelity simulator. And so that's kind of where we are. A low fidelity simulator would be more like a practice where you can practice basic skills. So sometimes they'll have heart sounds, but not or heart and lung sounds, but not necessarily chest rise and fall. They're more for like skills-based training versus a interactive simulation, although they can be used in many ways. As some of you said, it's an innovative teaching strategy. It's also very evidence-based. It's grounded in foundational learning theories such as constructivism, which really places the learning on. Learning is learner-centered, which we strive for with active learning. I'm sure many of you have students tell you that they learn by hands-on, and that's how they want to learn. And so simulation is a perfect setting for them to be able to do that. It's also been heavily researched as far as like being effective. There's some areas of simulation that are not heavily researched, which we'll talk about that later. But it is an effective teaching strategy, and that's kind of been established not only in nursing literature, but in many other disciplines as well. As we said, it's a safe learning environment for mistakes. That is also really important to tell the students, especially for end-of-life simulation. Some of them, depending on their personalities, they may strive and may make it harder for them to make mistakes, but we try to set that environment up for them. Really important for nursing is development of clinical judgment and thinking. The NCSBN, which is our state, the NCLEX, or our licensure exam, recently came out with the clinical judgment model. Simulation is a perfect way for them to practice this and learn in that model. Obviously, they're usually working in teams. You can't do much with simulation as an isolated activity, so they're usually working in teams with each other as students, and oftentimes, like we're going to talk about today, collaborating with another discipline, or sometimes they're just collaborating with me over the phone as their pretend provider. Also mixed in there is building of clinical skills. Typically in this scenario, students are practicing something, whether it's simple as communication, which is what this simulation is heavily focused on, whether it's something like starting an IV, whether it's administering a medication. Those are all skills that are really important. We try to target skills that are going to be safety, key safety practices, and deliberate practice, meaning they can practice those repetitively in a safe environment where they're not going to hurt anyone. We can also customize scenarios. Much of our scenarios are built out of things that the students don't see very often in clinical. They're also built out of evidence-based simulations, and so we can customize them. For example, we, through use of data from our program, we discovered that TPN, total parental nutrition, was a weakness for our students, and so we built that back into some of our simulations to help learn that. And then it's a great opportunity for reflective learning and debriefing, and we lead them through that in an evidence-based model. So in NAXL, I'm going to get the abbreviation wrong if I say it, the International Nursing Association for Clinical Simulation and Learning, they are responsible for issuing the healthcare simulation standards of best practice, and this is their cornerstones of best practice. So what does simulation actually look like? There's a pre-briefing component, a huge facilitation component, which involves some of the things we're going to talk about in just a moment. Professional integrity. Most of the time when you're doing simulation, it needs to be someone who's trained in simulation, and the students need information about it as well. And then one of the most important things is debriefing. Any questions about any of that? I feel like I'm talking really fast. All right. The next one is a Slido question, so if you'll get your device out, answer this question. Nursing simulation only focuses on technical skills and do not involve critical thinking or decision making. It's 100% false. Good. You guys are fast learners. Very good. And so again, we love simulation because it can reinforce many of those thinking skills. Just talking about us for a minute, I'll just brag on our simulation program for just a second while I have an audience. We have a simulation champion model. Professor Joel Foster is our simulation coordinator and does a lot of things to keep us on the right track. Those of us that are delivering simulations have some kind of expertise in the simulation that we're utilizing. So in other words, I don't go conduct an OB simulation, or most importantly, I don't debrief an OB simulation, which is mother-baby or delivering babies. We have an evidence-based curriculum. We use a pre-briefing script. We use a particular debriefing method, and then we always have evaluation for our students and then for us as well. We utilize simulation in a variety of ways. The simulation that I'm talking about today was used for clinical hours, and so any clinical hours in nursing is regulated by the Board of Nursing. Essentially, no more than 25% of direct client care hours can be counted for simulation, and so that works out to about 125 hours of their clinical time, which is 500 hours. Only 125 hours can be clinical. Also, they regulate how many clinical hours can be in each course, which is 50%. Most of us also use simulation in some way in the classroom, and we also use it heavily in lab teaching, maybe not to the full degree that I'm talking about today, but we try to bring it in because it is such a good tool. We collaborate with the Central Virginia Center for Simulation and Virtual Learning. Many of the pictures you see today are from their center. It's an amazing center, it's an amazing collaboration. We're very grateful for them and our use of their center. Okay, so we're going to shift gears a little bit and actually talk about the simulation that I did the research on, which is an end-of-life simulation. So this is what the students walk into initially, but it didn't just pop up overnight like this, okay? So a lot of simulation requires a lot of development. Oftentimes it's just the conversation that starts it, or it's reviewing of the data that starts it, and that would be part of a needs assessment. So for me particularly, this simulation I inherited from another faculty member. It was already being run. We have tweaked it and added things to it, but essentially a lot of things in our curriculum, because it is a simulation, we have a curriculum, as long as they're continuing to be effective, we continue to use them. We also consider what types of clinical experiences the students are having, and like I just said, we try to base things that they may not see as much and or would be really hard for them. Professor Shin does a scenario where they have to do CPR on a patient, or he's having chest pain and they have to do CPR. While the students may be involved in that in the clinical setting, they're not going to be the ones bearing sole responsibility. But in simulation, we can make that where they're not solely responsible, but their team is responsible. And so a lot of times in end-of-life care at the bedside, students are kind of observers. They're not really actively engaging in the conversations, whereas in this scenario, I kind of forced them into that conversation in a gentle manner. The other kind of cool thing that has happened, this scenario, like I said, has been run probably since pre-me, so like 2015, 2016. But the other cool thing that's happened, and we're kind of ahead of the curve on this, is the American Association of Colleges of Nurses, which is who we're accredited through CCNE as part of their organization. In 2021, they released new essentials, which we've been working through and on, and they listed out spheres of care. And so one of those spheres of care that has been identified is end-of-life and palliative care. So it's kind of risen to the forefront of something that's really important, so it's kind of cool that we were ahead of that. It's also a subject that's on NCLEX, so we use that to validate a lot of what we do, which is really important. As in most things, we don't do things without evidence-based practice, so we use a lot of references. We make sure what we're doing is still evidence-based, it's still up to date. So like it's been run since 2015, but that does not mean it's been stagnant since 2015, right? It's a lot of work to try to keep up and make sure we're doing what's appropriate for clinical practice. The timing of any simulation is especially important. This scenario, like I said, there's a lot of communication component to it. And so when we're considering where to place simulations, we also consider skill acquisition and then what setting are the students practicing in, and kind of where do we want them to utilize this, or where do we want them to practice this. For this semester where we run this scenario, we really want them to focus on some interprofessional communication with each other as well. And so it's an appropriate place for that. And so that's really important to us, as well as making sure that our students are prepared, but that we also challenge them to continue to grow in that setting. So this patient is in a hospitalized room. End-of-life care does not always happen in the hospital. Some of you may have experienced end-of-life care in a home setting, and Professor Foster runs a simulation about end-of-life care in a home setting. This room could also be in a long-term care setting, right? And while we run this scenario in medical surgical nursing, I oftentimes tell the students, like, a lot of what we talk about here is applicable to any setting for end-of-life care because of how we focus and what we do. So as part of kind of the development of this, it became clear that the use of a standardized patient or a standardized family member would be really important, because the patient in this scenario does not talk, okay? She's to the point where she's unresponsive. And so the family member does a lot of the talking, which I'll talk about that here in a minute. And then it became clear that it would be a really great opportunity to utilize chaplains, because students tend to not understand what a chaplain is in many ways, and so it was a great opportunity for that to be developed as well. Just some objectives. So all of our scenarios have the same 3 core objectives to some degree. And so we try to make sure that the students are clear about that. We try to make sure when we're developing it, everything we do is targeted back to the objectives. I already talked about that a little bit. And so this mannequin, she's a high fidelity mannequin, and she does breathe. She has pulses and things like that. And that's really important for the second part of the scenario, which we'll talk about that, because she actually dies and the students have to pronounce her and notify her family that she died. Okay, so this research question kind of developed out of a prior study that another faculty member had done on a different scenario where we use a medical interpreter. So we have a scenario where the patient is Spanish speaking and we bring in a medical interpreter. And so Dr. Joanne Newton, who's since retired, she did research on that scenario. And based on that, I thought, well, would we also apply that to this simulation? And so the question was, is simulation an effective method to teach about chaplain services? And how does exposure to the chaplain services impact their knowledge, competence, and comfort level in communicating with chaplains in patient care? So I chose not to focus on end-of-life care for this part of the research. I do think that's an area that could be developed further. I won't say that right now. I was going to tell you about chaplains and end-of-life care, but I have a question about that. So learner readiness is very important for simulation. That's part of the pre-briefing. And so our students go through a process of preparation. And part of that is looking up information that they may have forgotten. So they learned it at some point, but they may have kind of trickled that. They didn't scaffold it and bring it forward, right? I'm sure some of you see that happen as well. So we have them doing things that hopefully will prepare them to come and have success. So this is part of building that safety. That's part of making them feel like this is a safe environment, so they're not coming in and being blindsided by something that they don't expect. Doesn't work as well in every simulation to do that, but in this simulation, I want them to be as prepared as possible to come in prepared. We actually have them watch a video interaction with an end-of-life care patient and a family member. And they don't know it when they're doing this, but that conversation mirrors a lot of what they're going to experience in the simulation setting. So that is kind of how they prepare. We have them look at a palliative care model, which I'm going to show you here in just a second. We have them look at kind of information about a chaplain, so they're not coming in blind. And so when I was doing this intervention for the research, I knew they weren't coming in blind to what a chaplain was completely. And you'll see some of that reflected in the statistics. Okay, so this is a Slido question. And what do you think of when you hear the term chaplain? Good. Comfort, spiritual, some religion, a minister perhaps. Good. Spiritual support, preacher. Good. So hopefully I can help understand what a chaplain is and what they do. But really important, and I think some of you guys really nailed it, spiritual support is really their kind of wheelhouse, which is why it works so well to have them involved in end-of-life care simulation. And many times in the hospital, chaplains are used for many things, and I will not do it justice if I try to explain everything a chaplain does because they're incredible. But in this scenario, and for most of the time, when a patient either needs CPR or they come in any kind of trauma or they're in the ICU and it's a withdrawal of care situation, usually the chaplain is present. And so a lot of death and dying things, chaplains are involved. And so this is a little bit of what I give the students. This is a palliative care and end-of-life care model. I could talk for an hour just about the differences between the two. If you're interested in that, let's have lunch and a conversation. But really when I talk to the students about where this patient is right nearing this point. She's on this trajectory over here on the red line, nearing death for them. And so we talk a little bit about this as their preparation for the scenario. This is part of the handout that they receive. It's a handout that the chaplains from Centra actually sent me to give the students. But I think it's really important to know that a chaplain is someone that's usually prepared at a master's level, and they are going through rigorous training. And I'll talk a little bit about how we use the chaplain residency program at Centra. And hopefully you'll get a little appreciation for chaplains as well. And then I talk about hydration and nutrition of the terminally ill. They don't know this, but the family member will press them on this, like why can't she eat, why can't she drink, that kind of thing. They also review what a DNR is, or, oops, sorry, that's okay, you can do this one. And that type of thing we talk through some things like that. So another Slido question, how comfortable do you feel talking about end-of-life care, either for yourself or for someone important to you? Good, so we have a lot of healthcare providers in the room, so we might have some skewed results, right? But typically, if I ask the students this question, where do you think they fall? On the lower end, right? Very uncomfortable, somewhat uncomfortable, even some nurses, right? I had a previous coworker who was like, anything end of life care? Absolutely not, it's all you. Like, I'm not doing anything like that. And so we talk about that. We talk about, and like I said earlier, we talk about kind of how to approach things with empathy. And we just kind of get them ready for the scenario. So they're not going in there blindly. They're not going in without some knowledge of what a chaplain is and what they're going to experience. These are the questions that they have to complete. So simulation is not just show up and have a great time, right? Simulation is, we try to have them prepared. We look at their simulation questions. We have them look up information. Sometimes it's just for a time, like a time constraint. We can't go over every single thing they need to know before they start. And again, hopefully they've scaffolded some of that information. A really powerful thing that we do with this worksheet is, and I wanted to make you all do it, but one of my coworkers was like, don't do that. So we have them write a letter to death and or draw a picture. And these are some of the examples that I've used with permission from the students. Some of them draw really incredible pictures. I would say it's about half and half. Usually half of them draw a picture and half of them write a letter. And I have them do that. And why I kind of wanted you guys to do that is because we all come with end-of-life bias, right? We all have some kind of thought about end-of-life. And as a provider of healthcare, right, we have to sometimes lay those biases aside. I know for me, like, I'm drawn to it. It's a love for me. And so I also have to be careful about that, right? That I'm so passionate about it that I can sometimes overlook some of the other complicated feelings for people that they may have. And so I'll just read this one to you aloud. The student wrote, "Dear Death, I don't know how I imagine you will happen or when, but I know you will happen when it's my time. I'm scared, but I know it's a part of life. I hope it has little to no pain, and I get to tell my family goodbye, especially my sister. I have experienced a lot of young deaths since graduation, so my one wish is that you will come after I live much of my life." And so a lot of these students come in with having experienced personal death, so I try to be very sensitive to that. I do give them, not an out, but I do give them an option to be an observer only and not a participant. Most of the time they do not take me up on that. They want to experience it, and we talk about how that can help them be a better provider with that. So, study logistics, we have a limited time in simulation. We have about 4 hours usually for simulation time. We usually run 2 scenarios, just some logistics, so 2 hours for one and 2 hours for the other. So I had limited time when designing this, so the target was for about 5 minutes pre and post survey. Also, to get the students to do it, I had to kind of tell them it wasn't going to be a huge burden for them. As the PI and as a simulation faculty, I had to be, and when I submitted my IRB, I had to be very careful about having someone else send the invitation. So I read the invitation to them, and then the administrative assistant had actually scheduled when the surveys would go to them. I reminded them several times about confidentiality. It was all handled through the administrative assistant. I never saw any responses. It was all attempted to be completely anonymous, and obviously was completely optional, although I did have really good participation. So when I'm doing that pre-briefing or talking through some of those things, that's when this study was kind of introduced to them. So that's kind of how I got the students ready. We also have to get the chaplains ready. The chaplains, they come in and do their normal role, okay? But they do need a little information about what they're walking into and what the purpose of this simulation is. And so we usually recruit chaplains. We've had retired chaplains, but recently our best collaboration has been with chaplain residents. So residents at Centra, they have a clinical pastoral education, and so those students, the residents that come over to our simulation are in the middle of their clinical pastoral education. So they have a master's degree in theology or whatever they're appropriate for their denomination a lot of times, but they're actively learning how to be a chaplain. So it's kind of cool. They oftentimes learn a lot too, which is kind of a cool thing. It can be tricky with chaplain scheduling, but we've been really fortunate. We've done this for a couple of years now, and so they kind of expect it, and they willingly volunteer their time, so it's kind of amazing. The last couple of times the residents weren't able to come, and we actually had just chaplains that practice at Centra volunteer their time, which was really amazing. This is a side note, the chaplains also go through some simulation, so they have some knowledge about what simulation is and what it does. We also have to get the standardized patient ready, and so we recruit volunteers, usually through the simulation center. I have myself had to be the grieving faculty member before. I think Professor Foster's been my grieving faculty member before. I've resorted to having students being my grieving faculty member, but it always works best if it's a volunteer. And I have one standardized patient at the simulation center who loves this role, and so he's like mastered it, so he's amazing, and I know what he's going to say and when he's going to say it, which is really important as the educator. But basically, they're a grieving family member who disagree with what's happening in the room. So they do not agree with the DNR, which is do not resuscitate order. They don't agree with anything of what's happening. They're not happy that the nurses aren't doing anything. And so that is kind of what prompts a chaplain visit. And that's how the chaplain kind of gets involved as well. So we'll talk a little bit more about how that works. Educator readiness, again, it's important for me to make sure that I'm focusing on empathy and those things. A lot of educator readiness is setting up and moulaging, which is making up mannequin, making it look realistic and believable for the students. There's also some scheduling things. We usually have a setup worksheet that we follow and that type of thing. So here's some more just up close pictures of her, since we're a lot of medical people in the room. I usually simulate a fentanyl patch on her, that's part of their assessment. She has an implanted port. They don't do anything with it, so it's not linked to any fluids or anything. And we talk about like end-of-life care orders and that type of thing. She has a scopolamine patch back here, which you can't really see, it's kind of falling off, but and then she has some things in her room that are prompts. She has her Bible, and I usually also hang up the DNR above her bed. On the monitor, I usually do put a set of vital signs. I usually talk to the students about this because an end-of-life care patient, you really don't need a monitor. In fact, a lot of times you turn the monitor off, but because they're brand new and it's their first scenario, I usually give them the grace of having the monitor. But we talk about that and why they wouldn't even need it. They have things in the room available to them like suction, a nasal cannula, although we talk about that in pre-briefing as well. When would you use oxygen for an end-of-life care patient? So a lot of that setup and moulage, I do that before the students get there, but some of it I do it kind of as they're arriving and as they're doing their kind of pre-briefing work, and we'll talk a little bit about that too. Psychological safety is a huge thing for simulation. The basic assumption is that we state this before every simulation, is that we believe everyone participating is intelligent, capable, care about doing their best, and want to improve. And again, that's very important for this type of simulation. I just tell them up front, end of life care is very gray. We've trained them thus far to be very black and white. The blood pressure is 80, you better do something, right? Systolic blood pressure is 80, you better do something. But yet, they're just gonna have to watch a blood pressure of 80/30 on the monitor. If she's having pain, they're gonna have to give her morphine if her respiratory rate is 5, right? So we talk a lot about how this is gray, and we talk a lot about, what that means. We talk a lot about the DNR that refreshes their memory from other things, and kind of what it means is from a legal standpoint. I also pre-brief them about the chaplain and the standardized patient, so they don't walk in there blindly, not knowing that there's a mannequin and someone in there with them. As I'm watching as their educator, I'll show you kind of where I watch from. I'm watching for certain behaviors from them, and so this is kind of my checklist of what I watch for them to be doing. That helps me know kind of when to end the scenario. This scenario is 2 parts, so roughly 2 hours is spent with a patient who's actively dying, unconscious. The family member is grieving. They are not comfortable with how things are going. The students have to go in and communicate through that process. And the students either offer the chaplain because they know it's available, or the standardized patient knows to prompt them to call the chaplain. So either way, the chaplain enters the room in this first scenario. How that goes, it just depends on the setting. And then in the second scenario, the patient actively dies. The standardized patient is still present, and they have to tell the patient, the family member, that the patient has died. I usually we don't have time to watch that. If you're interested in empathy video, I can send that to you. If I can get past it. Might be watching it anyway. It's an older video from the Cleveland Clinic, but it's really powerful. And oftentimes I have them watch that too in pre-briefing. So how this logistically happens, most of you have probably been here and know how this happens, but I have usually around 6 to 8 students in simulation, preferably 6. And so I have 3 of them watching and 3 of them actively in the room. And watching means that they're actively observing. They have a worksheet that they're completing that we have standardized through our program. And then I'm watching in the control room. Usually in this room, I also have the chaplain with me, and the chaplain will actually answer the phone when they call, and they request the chaplain and that type of thing, and so I usually send them in from there. So this is what the scenario looks like from a camera. This person over here is a standardized patient. You can see his hand, he's got his coffee. They're instructed to, not agree with how things are going. Usually they talk about having a fight, and so it gives a chaplain an opportunity to talk through some of that. And then here are 2 students over here, and then here's the chaplain that's entered the room. So just so you can kind of see how it plays out there, and how that works. Debriefing. So in the part of the research question, right, was talking about the chaplain and the knowledge of chaplain. So this first debriefing, so I know I'm kind of rushing through what happens in the scenario. If you're interested in that, we can kind of talk more. But the chaplain debriefing is really, really critical. They come in and talk to them about the chaplain role, and that was really critical for the research question. After the scenario 2, when the patient dies, we do an expiration checklist, we do post-mortem care. We used to bag the mannequin in a body bag, and now they have a cord that is hard to remove, so we've kind of sufficed to put it on top of her. The standardized patient talks to the students about what they did, and we have them do what's called debriefing for meaningful learning. And so the students use a reflection worksheet. And so these are kind of some of the things that they usually say. And so one of the questions in debriefing is kind of, what is the first thing that comes to mind about the experience you just had? And typically it's something like, it was hard, it was difficult, It was sad, depressing, eye-opening. These are some of the ones that they said as well. I never knew how I would feel until I experienced it, and you don't know how someone will respond. I think the student was talking about how hard it was to speak about death openly. They felt touched and honored, sad but rewarding, and then brought up a lot of personal memories. So that component of it is very important. We usually spend a lot of time, I usually spend a lot of time trying to make them, I don't want them leaving feeling defeated or that they have some kind of like unresolved emotions. They may feel a certain way, right? But I try really hard to make them feel as comfortable as I can with it. Usually they've made it through this whole entire scenario and never once have said the word die, dead or dying. Okay, so we usually all together say the words dead, dying in the scenario because while we can say things like pass away and things like that in our day-to-day conversations, there's a lot of really strong end-of-life evidence that says we cannot say those words as healthcare providers. So that led to kind of how that whole scenario was played out. And so what happened was with those surveys, those were the questions that were asked. I have the knowledge and skills to communicate effectively with the chaplain. I know when and how to use chaplain services in my nursing practice. I feel comfortable including chaplains in my nursing care. And then I included more of a qualitative question or an open-ended question, just describe the role of the chaplain, which I already had you guys kind of do. And so this was the graphic of what happened pre and post survey, but I have some. So here you can see this first question. They were mostly neutral about having the knowledge and skills to communicate with the chaplain. For this one, I know when and how to use my chaplain services. About half of them already felt like they knew, and I think that was probably because they had done some preparation already. And then this one was I feel comfortable including chaplains in nursing care, and again about half of them agreed, and again I think that was probably because they had already learned about chaplaincy through that handout in the article that they read. Post-survey, everything kind of improved, which is good, right? Unfortunately, I did lose 5 people didn't respond to the post-survey, so not a huge loss, but I don't think it was statistically significant, but still worth noting. The knowledge and skills to communicate effectively with a chaplain significantly increased. The majority of them agreed or strongly agreed. I know when and how to use chaplain services. Again, most of them agreed or strongly agreed. And then I felt comfortable including chaplains in my patient care. Great majority strongly agreed with that. So that was reassuring to say that, when we answer our research question, that we could answer it fairly confidently. So again, those are just the statistics broken down of kind of where we ended up. The most improvement was in the knowledge and skills to communicate, which made sense because that's what they were mostly able to practice in the scenario. These are the things that they described the role of the chaplain. Pre-survey, they kind of already knew in some ways support, which many of you said emotional and religious, focus on family and patient, and death and grief. And then post-survey, it was more of a spiritual focus and includes providers as benefiting from chaplains. So that's something that the chaplain often talks about is how chaplaincy is not just for patients and their families, but also for healthcare providers. So the conclusion to the research showed that nursing students' perception, knowledge, competence, and comfort level improved after the end-of-life scenario with interprofessional chaplain services. The analysis of the data also supported the effectiveness of the simulation as a teaching modality. And so, again, we've continued to use this scenario, and it's continued to work well. Future considerations, one limitation of this was that we do not have consistent standardized patient and consistent chaplain, right? So the roles kind of vary with each person. And so that was somewhat of a limitation, but they typically all do the same thing just because they're given instructions in the worksheet on how to do that. And so future considerations, collaboration for a grieving family member to maybe make it more consistent which that has happened recently a little bit more. A reflection journal for the students, really continuing to reflect on the patient, that patient care. Repeating this, again, with a different cohort or level, and then maybe using a different interprofessional provider. Case managers and things like that are important for nursing care as well. And then I didn't focus on studying kind of the impact on views of end-of-life care, but that is something that I would be interested in, kind of a pre and post survey for that as well. Okay, before I get to that, does anyone have any questions? Yeah.
Did you see any difference, or was it in your post survey of the students who physically participated in the simulation, and how they took the learning experience versus the students who were watching observers of it?
I did not pull that out. No, I didn't have that pulled out in the statistics, but I will say that the students who participated in that first scenario, we switch off so they are, if they're watching the first scenario, they participate in the second one, if that makes sense. So they participated in some of it, maybe not the interaction with the chaplain, but then they all get the debriefing with the chaplain. So does that make sense? Any other questions? Yes.
Do you also train students on how to manage themselves emotionally in that situation outside of the technical aspect?
Yes, we talk a lot about that. I didn't include that in here, but we talk about self-care. I showed them a video called The Pause. Some of you may know that as well. It's a model where after any patient death in the hospital, you take a pause, like you literally stop what you're doing to recognize that life. And so we try to talk through that. I oftentimes link that back to their picture and their letter, and help them reflect on that. The chaplain also talks, usually most of them talk about what services they can offer staff and things like that. I know certain healthcare systems, especially post certain kind of events, they will have a debriefing with the staff, and I'm not saying that it's good enough, because I know it wasn't good enough when I was a nurse, but I very heavily acknowledge that they may live with a lot of feelings. Also tell them that they're welcome to come talk to me separately, and some of them, I would say, especially if they've had recent death, they will come talk to me about it, either before or after. Thank you. Any other questions?